Hello everyone, welcome back to our channel. And for today's video, we are going to start a discussion about the disorders of your gastrointestinal system. Okay, but before we proceed to the actual discussion and with the first disorder, if you are not yet a subscriber, don't forget to subscribe to our channel, hit that like button, comment and share these videos with your friends. Okay, so disorder of the gastrointestinal system. So basically, this video series is about disorders from mouth to anus. So to start with this video, the first video that we're going to do is about one of the most common problem or disorder in the GIT system, which is your GERD or your gastroesophageal reflux disorder. Your gastroesophageal reflux disorder, according to the book of Brunner and Sodar, is a condition wherein there is a backflow of gastric and duodenum contents into the esophagus. So if you are familiar with the anatomy and physiology of your gastrointestinal system, so from mouth, okay, when you chew food, when you swallow, it will go now or pass through to the elongated tube, which is your esophagus. And it will go now to the pouch, which is your stomach. So these two organs is actually separated by a sphincter, which is your lower esophageal sphincter. And because of that, the food that already entered the stomach will not go back, okay, into the esophagus, or will not regurgitate into the esophagus. Okay, that's actually the normal physiology, and it will go now to the small intestine, which is the next organ after the stomach, and specifically in the first part or portion of the intestine, small intestine, which is your duodenum. So once the food enters now, the gastric content, once it enters now your duodenum, it will not go back to the stomach, okay, because it is separated by a part of the stomach or even the duodenum called your pylorus. So basically it's a flap that will not that will try to cover, okay, or to prevent the duodenal content to reflux, okay, or to go back into the stomach, okay, or to the previous organ that it came from. Okay, so yun po yung ang normal physiology, anatomy and physiology ng ating gastrointestinal system. So what happened in your GERD is that this process is actually becomes problematic. Why? Because it's either there is a problem in the lower esophageal sphincter or in the pylorus of the duodenum and your stomach. So basically, whatever content of the stomach is or the duodenum is backflowing from that part into the esophagus, causing now the gastric content to endure because it contains acid that can endure the mucosal lining of your of the patient's or the person's esophagus. Okay, now your gastroesophageal reflux, as I've mentioned, okay, is caused by the several factors or several causes. Number one there, which is the most common, we have your incompetent lower esophageal sphincter. So your incompetent lower esophageal sphincter is the most common cause of your GERD. Okay, just like I said, this if this is your esophagus, this is where your sphincter is located. Okay, and that is your stomach, and this is your pylorus before it will go to your duodenum. So once the food enters the stomach, okay, this sphincter here, it's preventing now the gastric content to backflow and goes back into your esophagus. So what happened is that this sphincter here becomes incompetent or loose, causing now it will always be relaxed, causing now this area to become open, and the gastric content tendency is to go back or backflow, okay, from the stomach into the esophagus, causing now injury in this area. Okay, another etiology or cause is the pyloric stenosis. So this is your pylorus or your pyloric. Okay, so the pylorus becomes hardens, okay, nagkaroon ng stenosis na tinatawag. So whenever you hear the word stenosis, okay, a particular organ, for this instance the pylorus, becomes hardened. So kapag yun ay nanigas, ganun pa rin, hindi siya mag-open. So whatever contents here will try to push, okay, push it into the esophagus, causing now injury to the esophageal lining. Other conditions that can contribute or can be a cause of your GERD is your hiatal hernia. We will have a separate discussion for this condition of the gastrointestinal system. Okay, and of course we have your motility disorder. So these four are the most common type or the most common cause of your GERD or gastroesophageal reflux. But among the four, okay, it is the incompetent lower esophageal sphincter ang pinaka common. Okay, now aside from these causes, okay, there are several factors to include, okay, into the development of your gastroesophageal reflux. Okay, we have your precipitating factors that includes the following. We have your irritable bowel syndrome, okay, followed by your COPD or your chronic obstructive pulmonary diseases such as your emphysema and bronchitis, to include your asthma and cystic fibrosis. Okay, included din yan ang peptic ulcer. We will have a separate discussion for this one. And of course, your angina, which is a cardiac disorder, okay, or a cardiac condition. So these four disorders or these four groups of disorders or conditions of the different system of the body can precipitate the development of your gastroesophageal refluxes. Okay, aside from that, there are several associated factors that can also contribute to the development of GERD or to the worsening of this condition. Number one is the tobacco use, because when you smoke, okay, when you use tobacco, okay, na-stimulate din po ang ating gastric area, okay, or stomach to produce more gastrin and other enzymes and acids that aids in the digestion. Okay, aside from that, we also have your alcohol and caffeine consumption. Your alcohol and caffeine consumption, same thing with your tobacco use, increases the production of these gastric components that actually is considered corrosive when it reflected, okay, or regurgitated into a place or a portion of the GIT that they are not supposed to be present. Okay, and the next one is your gastric infection. Most common is your H. pylori infection or your Helicobacter, okay, which is common sa mga pasyente na may blood type O. Yes, you heard it right. So mga pasyente na may blood type O, okay, are actually at risk, okay, in developing gastric infection, which may later on lead to the development of peptic ulcer disease. Okay, kasi mas according to a lot of study, though they don't have the exact data on why is it happening, but according to a lot of study, patient with blood type O actually has a significant number of H. pylori in them. Okay, so those are the associated factors and the precipitating factors that can contribute to the development of your gastroesophageal reflux. Now, once this condition already occurred, these are the expected clinical manifestations that you would expect. Number one, patient may have pyrosis. So when we talk about pyrosis, this is what known as your heartburn. Okay, heartburn. Your pyrosis or heartburn happens when because of the reflux of the gastric content. Okay, because of the reflux of gastric content, it causes now injury into the esophageal lining, causing now pain sensation, which is verbalized by the patient as heartburn. Okay, and the medical term for that is your pyrosis. Aside from that, okay, pwede tayong magkaroon ng dyspepsia. So dyspepsia is indigestion. Okay, indigestion. Aside from the indigestion, patient will also suffer from regurgitation. Okay, whatever food intake you have in there, okay, in your stomach, so nagre-reflux siya. So that's your regurgitation. And aside from that, dysphagia and odenophagia. So dysphagia and odenophagia, they're actually somewhat both related to swallowing. Pag sinabi nating dysphagia is the difficulty of swallowing, and if that difficulty of swallowing is due to painful sensation, ang tawag natin doon is odenophagia. So odenophagia is the painful, okay, painful swallowing, while your dysphagia is your difficulty, okay, difficulty of swallowing. So dysphagia, difficulty of swallowing, odenophagia, that's your painful swallowing. Next is that patient may also manifest hypersalivation, and of course, due to the constant regurgitation of the gastric content, it will injure the gastric lining that may lead now to your esophagitis or the inflammation of your esophagus. And if you combine all of these clinical manifestation, okay, they're actually mimic the signs and symptoms of your heart attack. Okay, this a combination of this clinical manifestation actually mimics the signs and symptoms of a heart attack. That is why when a patient is brought to the ER, okay, pag may tinakbo na pasyente sa ER and the complaint is chest pain, there are two things that the doctor, okay, or the ER residents will need to rule out. If it's cardiac by nature, okay, or or gastric by nature. Kaya nga, aside ang mga pasyenteng ito, okay, na nagko-complain ng epigastric and also chest pain were actually given with proton pump inhibitors. This is to decrease now the secretion of your gastric content, which hopefully rule out kung gastric by siya by nature or a sign or a condition that is heart, okay, or cardiac by nature. Okay, so those are the clinical manifestation. Now, how are we going to diagnose this condition? There are several tests that is needed to perform, okay, in order to rule out your GERD or gastroesophageal reflux. Number one is, of course, to visualize. To visualize now the gastrointestinal system, specifically your esophagus, to include your stomach and duodenum. Patient may undergo your endoscopy or endoscopy with barium swallow. Okay, aside from that, patient, okay, may undergo also your ambulatory 12 to 36 hours esophageal pH monitoring. So this basically monitors the pH level of the gas of the esophageal area, okay, in relation to the reflux that is happening. So titignan nila kung gaano kataas yung acidity na meron sa esophagus ng pasyente. And this is attached with a catheter. Okay, another almost the same diagnostic test that they perform with patient with GERD is your wireless capsule pH monitoring, which is better tolerated by the patient and it's quite accurate. They have the same principle, measuring, okay, measuring the pH of the patient. However, kumpara sa ambulatory 12 to 36 hours, your wireless capsule monitors patient for a period of 48 hours. And since sabi nga dyan, it's wireless, wala po siyang catheter. While your ambulatory has catheter. Okay? This has catheter and your wireless has no catheter. Kaya nga sabi, mas convenient siya or tolerated by the patient compared to ambulatory 12 to 36 hours pH monitoring because this one has no catheter. So the wireless has no catheter, ambulatory has catheter. So those are the three diagnostic tests, okay? But so whichever the two pwedeng gamitin, okay, whichever is available, okay? So we can make use of the ambulatory or the wireless. So mas convenient ang wireless kesa dun sa ambulatory. So 48 hours ito, 12 to 36 hours naman po ang ating ambulatory. So wireless is 48, ambulatory is 12 to 30. Okay, so we already know the diagnosis. Okay, so using the diagnostic test that we have, we've established the clinical manifestation of your gastroesophageal reflux. The question now is, how are we going to manage the condition? Okay, so these are some of the management that we need to emphasize to our patient. And of course, as a nurse in the future, okay, we also need to know about this in order for us to deliver the intervention or the management to our patient properly. Number one is that we have to avoid the following. Okay, there are certain things that we need to avoid. Okay, the patient need to avoid, and as a nurse, we need to emphasize this to our patient. These things will actually exacerbate the condition or it will make the condition worse. So that is why we ask the patient to avoid this following. Number one is that we have to ask the patient to avoid caffeine and milk because these two, okay, these two beverages would actually increase gastric secretions, okay, which will actually exacerbate or worsen, okay, or worsen the condition. So avoid caffeine and milk, okay, caffeine and milk. Another one is tobacco and alcohol. Okay, as we already know, one of the or two of the associated factors of your gastroesophageal reflux is the use of alcohol. I mean, the use of tobacco and the consumption of alcohol. Aside from that, okay, avoid also peppermint and spearmint. Okay, it's the same principle here. It will actually increase the secretion of the gastric content. Plus your carbonated beverages. Take note that carbonated beverages contains acid, and the problem already is an acid reflux. So once you drink carbonated beverages, it will now still increase the secretion of these acids, causing now more regurgitation. And aside from that, carbonated beverages will also develop yung tinatawag nating flatulence. Magkakaroon tayo. These are gas forming beverages, and when there is an increase gas formation or hangin sa ating tiyan, it will also increase the pressure, causing now more regurgitation kasi nga yung pressure tumataas. Aside from that is your tight-fitting clothes, and also avoid eating and drinking 2 hours. Okay? Avoid eating and drinking 2 hours before bedtime. Ibig sabihin, no more midnight snack. Okay? No more midnight snack. So that is the things that you need to avoid, and we have to emphasize this to our patient. As a nurse, this should be part of our health education. Aside from that, in terms of the nutrition, okay, in terms of the nutrition, as a part of the medical and nursing management for patient with gastroesophageal reflux, number one there is that we have to advise the patient to maintain a diet, okay, of low fat. Okay, maintain a diet of low fat, because more fat would also increase or stimulate the increased production of your enzymes and gastric components or gastric content of the GIT. Okay, and we have to maintain also a normal body weight, and in terms of this one, we have to monitor the weight daily. So kung kailangan timbangin yung pasyente, then we have to do so. Number one, okay, patients should be on a small frequent feedings with appropriate foods. So small frequent feedings, because the more food you consume, the higher the chance that the pressure inside your stomach will also increase kasi nga puno siya, full. Okay? And because there's a lot of food, it means to say that it requires a lot of gastric acid as well to digest this food. Okay? So if there's a lot of food plus a lot of gastric acid tendency, there's a higher chance that it can also regurgitate and develop now again into a reflux. That's why you have to provide a small frequent feeding to the patient. And of course, when talk about small frequent feeding, it has to be with appropriate foods. So appropriate foods, bawal yung may caffeine, bawal yung may alcohol, bawal ang tobacco. It has to be low fat as well. Aside from that, okay, you have to instruct the patient to eat slowly and chew the food thoroughly. Okay, chew the food thoroughly. So this would actually help the gastrointestinal system to easily digest the food. Okay, para hindi po siya naiipon lang and then magre-reflux lang once the stomach becomes full. Okay, and we have to weigh the patient daily, as I have mentioned earlier, because the patient needs to maintain a normal body weight. So that's part of the nutritional medical management. And the last one is to remain upright position. Okay, or the patient needs to be in a upright position or a high Fowler's position after eating, or okay, at least 2 hours after eating, 2 to 3 hours after eating. This is to prevent again reflux of the gastric component or gastric content due to the gravity. Okay, so that's part of the nutritional nursing management, medical and nursing management for patient with GERD. Now, we also need to position the patient in a semi-Fowler position when the patient is about to sleep or kung siya ay matutulog. Okay? So this will now decrease the risk of aspiration for patient with difficulty of swallowing. Okay? So if you're going to maintain a semi-polar position. Another management is that we can give drugs that can actually decrease the production of these gastric secretions or gastric acids and gastric enzymes. There are several drugs that can be ordered by the doctor to provide or to give to our patient as prescribed. Number one there is your antacids. So antacids is basically to minimize the production of your, to minimize the effect of your gastric acid into the mucosal lining of your GIT. So by coating it with these drugs such as your calcium carbonate, okay, almag or your aluminum magnesium and your aluminum hydroxide. So all of these three are examples of your antacids. Another one is histamine receptor antagonist. Example of this are the drugs that ends with tidine. So example is your ranitidine. Yan, ranitidine. So that's example, ranitidine, cimetidine. So all those drugs that ends with tidine are histamine receptor antagonists. Okay. Aside from that, there is we need also, or the doctor may also order prokinetic agents such as your metoclopramide. So metoclopramide are actually antiemetic drugs, okay? Para hindi magsuka or maiwasan or mabawasan yung tendency ng regurgitation or vomiting. Okay? Aside from that is your PPI or your proton pump inhibitor. So sulat natin dito, PPI or your proton pump inhibitors. Your pump inhibitors are drugs that decreases the stimulation of gastric cells to produce gastric acids. Okay, and these drugs actually ends with prazole. So example is your omeprazole, pantoprazole, esomeprazole, mesoprazole. So those are example of your PPI or your proton pump inhibitor drugs or medications. Next is reflux inhibitors such as your bethanidol chloride. Okay, because the condition is Gerd, gastroesophageal reflux, so we can also give reflux inhibitors such as your bethanidol chloride. And also your surface agent, which is your sucralfate. So these are the pharmacologic treatment that can be considered by the physician to order to patient with gastroesophageal reflux. Now, after all this treatment, medical and nursing management, if all of this fails, okay, patient may also undergo a surgical management. And for the surgery, we have what we call your Nissen fundoplication, or you also known as your gastric wrap around. So your gastric wrap around is a condition wherein part of the stomach will wrap around the lower esophageal junction or the lower to promote yung or to fix the loose or incompetent lower esophageal sphincter. So if you try to research online, okay, so I've taken this picture from online. This is what the Nissen fundoplication looks like. So this is the normal, okay, stomach. As you can see, the normal stomach. That is the esophagus there. This is the lower esophageal junction where the lower esophageal sphincter is located. And this is the stomach. And here is this pyloric stenosis, and this part is your duodenum. So what they did is that if the condition is due to the loosening, okay, or the incompetent of the lower esophageal sphincter, they're going to take this portion and wrap it around into the lower esophageal junction, okay, to promote now or to create now an alternative constriction, okay, into this area to prevent the gastric content to reflux into your esophagus. Okay, so that is your surgical management, Nissen fundoplication. Okay, so that those are the management that needs to be considered, okay, by the physician and to be ordered and to be performed or implemented by the nurse. Then as a nurse, these are the possible nursing diagnoses that you have to watch out for. Number one is imbalanced nutrition, less than the body requirements, because as you can see, okay, it's gonna be hard for the patient to adjust to the nutritional problem or imbalance kasi nga nagkakaroon ng problema sa GIT. Okay, there are tendency ng pasyente natin is nahihirapang lumunok because of the esophagitis, causing now anorexia or hindi makakain ng pasyente. That will later on affects the nutrition of the patient at yung kanyang timbang or pwedeng bumaba ang kanyang timbang. So imbalanced nutrition, less than body requirements. Another one is risk for aspiration. So risk for aspiration because of the reflux. So because of the regurgitation, there is a tendency that some gastric content will go into your lungs, okay, through your bronchus, okay, and it will cause now aspiration that may later on possibly lead to aspiration pneumonia. Next is acute pain because the patient has esophagitis. So acute pain related to, okay, the condition which is your related to condition because nga meron tayo ang tissue injury because of the regurgitation of gastric content. And the last one is knowledge deficit or deficient knowledge. If the patient has unable to have an idea or any some sort of knowledge about his or her condition and ways on how to prevent it. Okay, on how to prevent it and how to manage it. So if the patient manifested um, cognitively that he has no idea on how the condition was developed, he has no idea what are the things that needs to avoid, he has no idea what are the things that need to be monitored and needs to be done in order to manage his or her condition, that is a clear example that the patient has a deficient knowledge about the condition. So that is basically your gastroesophageal reflux. Let me just give you a quick recap again. When I talk about gastroesophageal reflux, it is the backflow of the gastric content, okay, from your stomach into your esophagus. It is because of a several etiologic cause, but the most common is your incompetent lower esophageal sphincter. Okay, it is also associated with some of the conditions such as your peptic ulcer disease, your mobility disorders, a hiatal hernia, okay, and also your COPD, asthma, and cystic fibrosis. It is also associated with tobacco use, alcohol consumption, okay, and when we talk about the clinical manifestation, the most common is your pyrosis, your heartburn, to be accompanied by your indigestion, regurgitation, indigestion, or your dyspepsia, regurgitation, your odenophagia, which is the painful swallowing, plus your um, dysphagia, which is your difficulty of swallowing. Hypersalivation and also your esophagitis is present, and all of this mimics the signs of a patient having heart attack. For the treatment, okay, for the treatment, you just need to avoid the things that can actually exacerbate the condition, such as your caffeine, milk, alcohol, and the associated factors. For the nutrition, it has to be low fat. Okay, weigh the patient daily. Do not eat. Okay, 2 hours before bedtime, and do not lie down 2 hours after eating. So the patient has to remain upright position to prevent aspiration for patient with difficulty of swallowing. For the for the medical treatment, we have different types of medication that can be given. We have your antacids. Okay, we have your proton pump inhibitors, histamine antagonists, and so on and so forth. And for the surgical management, we have your Nissen fundoplication, or also known as your gastric wrap around. So for the possible nursing diagnosis, it is in your screen. So all of those are the information that you need to know about your gastroesophageal reflux. So if you do have questions, please don't forget to comment it down in our comment section. And of course, don't forget to subscribe, like, and share this video to your friends. That would be all for today, guys. Thank you for watching and see you in my next video.